Hello lovelies, and welcome to today's video. My name's Alya and I'm so glad you stopped by. Today we're talking about screening for familial diseases. Oi, what a mouthful. But there are 3 specific diseases which I am very passionate about people checking on if you have a primary or secondary relative that has that disease. Could be a grandparent, could be an auntie and uncle, but it's so important to screen all the grandkids, all the nephews and nieces, because it can be a trend in families. So there are 3 that I'm really passionate about people checking up on, and stick around to learn all about them. Today was one of those days, guys. It was just one of those days. I guess just typical me fitting too much in, but also typical my work trying to fit in too much, and trying to see everyone and not turn anyone away when they're in trouble. So very fulfilling work I do, but it also makes me stop and think about all those people out there who are potentially missing out because clinics are overwhelmed, especially after COVID. And what's the solution? You know, what can people do? And that's why I've chosen to do this topic, because there are some things that shouldn't go unreviewed. And I've got some solutions as to how, at least in Australia, from what I know, how I would go about doing them. So where do I start? It's really complicated, because I wish I could just, you know, there are more hours in a day, more days in the week, and I was able to do more for more people. But really, I'm not the solution. I'm only someone observing the problem. So to elaborate, to explain, we often see people who don't need an ophthalmologist. What they need is a absolutely non-referral, off the street, very pedestrian optometry review, or as I call it, shoptometry. When I say that, I don't mean any disrespect to optometry. I think optometrists are remarkable people. They have a very not straightforward job. They have very interesting challenges, to say the least, in their work. You know, I'm in awe of a lot of optometrists with some of the stuff that they have to deal with on a daily basis. You know, while I'm sitting there in my little cushy referred to, you know, nice little job. So I definitely take my hat off to the kind of work optometrists often have to do. So that's not what I mean. What I mean is that any optometrist, even with minimal experience, can see to a family trend or a genetic trend. Now, today we're not talking about genetic disease per se. I'm not talking about, you know, things like Leber's dystrophy or retinitis pigmentosa, or things that will need an ophthalmologist and a geneticist and all that sort of stuff to kind of map out. I'm talking about more mundane, more run-of-the-mill type of diseases. Things that are super duper common and appear typically much later on in life and need to be seen to because they're incredibly silent. They carry very minimal symptom. And that is things like glaucoma, very big one. The other one is macular degeneration. And the third one, and this is one that's very frequently missed, amblyopia. So those are the 3 things I'm going to focus on today. So just to quickly elaborate what they are. Glaucoma is a very interesting disease. It was previously known the silent cause of blindness. It used to be, back in the day, the biggest cause of blindness in Australia. Thankfully, that statistic has now been turned around and we no longer have such high numbers of blindness through glaucoma, but it does very much still happen. Glaucoma is the death of the nerve at the back of the eye. So the optic nerve just stops working over time, and it does it because for some reason, and there are a few theories still out there, there's a couple of schools of thought as to how. One theory is that the optic nerve flow, so that all the little feeder nerves that sit in the retina cannot feed that beautiful big optic nerve at the back because they're being squashed. Sometimes people are suggesting in the studies that it's a physical squashing, so the pressure is physically stopping the flow of the nerve from happening. Another theory, which is becoming a little bit more commonplace, so I'm reading about it more and more, and that could just be just the literature I'm coming across. I haven't sort of intentionally researched it, but you know, just in my readings. I'm finding a lot more people are talking about blood supply or blood flow to the eye being the cause of a lot of things. And you know, a lot of research going into the concept of the way the blood enters the eye and supplies individual layers and different layers and individual cells or cell types may very well hold the secret to a lot of diseases, including macular degeneration, but I'll go into that in a minute. But definitely an explanation to how glaucoma happens. But the reality is that as a clinician and as a patient, that shouldn't really be your main concern. People are really overly focused on pressure. And the reason for that is because when we go to treat glaucoma, when we can confirm that someone already does truly have it and that's a concern of theirs, that's all we really focus on. We focus on measuring the pressure a lot. We set goals, we set pressure targets, and we're very much into meeting those targets, because that means the eye is, it's a sort of the safety maximum that the eye can reach. Now, a normal eye, a normal person that doesn't have glaucoma can have pressures as high as 20 without raising any alarm bells. Any higher than 20, and we consider that ocular hypertension, not necessarily glaucoma, because again, it doesn't mean that the nerve is going to die, but that is a very high pressure, and that's something that person needs to have regularly reviewed. But how do you know that your pressures are 20 or not 20? And how do you know whether your nerve is dying or isn't dying? Well, the reality is you can't know. You won't know until it's dead, until you've gone blind. And it's an irreversible kind of blindness, which is why it was such a successful disease for so many years in sending people blind and being the leading cause of blindness in Australia anyway. So the solution, of course, is to have regular checkups, not just checkups every so often in random places. I would pick a place and stick to it. The reason is that these days we have these really extremely intelligent machines that do a lot of the measuring for us, or we use to measure. The thing about that is that the accuracy has just gone up a millionfold. I couldn't even tell you how much more accurate not just diagnosis and treatment has been, but also referrals have been coming through with far more intelligence, with far more insight than what we were previously seeing. And the biggest reason for that is the OCT, because OCTs now are becoming really commonplace in optometry practice. So coming back to that shoptometry concept. Now, the reason I call it shoptometry, very lovingly, coming back to my original thought, is that people come in thinking, I need to check my eyes for glasses. You get to around the 40 mark, reading's getting a little bit harder, and the optometrist says to you, well, I might be new at this and all, but I'm not loving the way your optic nerve looks. Can I just do a scan? It's going to be a little bit extra. It's usually about $30 or so, because it's a really, as we say, you're paying for not the machine, not the test, but the experience of the person interpreting it, really. So even if it costs you $50, irrelevant. You say yes, because if they're already thinking there's something going on, they're probably onto something. So you get this scan done, this extra test done, you pay a little bit extra. And where does it get you? What does it tell you? What it does is it scans and measures, a bit like having an ultrasound, all the different layers at the back of the eye, and it really truly isolates which layers are having a problem, or which layers are not statistically normal. Nowadays, we're getting far less glaucoma suspects that aren't actually glaucoma. A lot of the time in the past, we would say, look, I know why the optometrist would have thought it's glaucoma, but now I've done my OCT, the doctor's had a look, with all of our years of experience plus our fancy equipment, we can tell you for sure that you don't need to worry, but let's just, let the optometrist double check in a couple of years just to be certain. That would be generally what we would say, because we were quite confident it wasn't there. Nowadays, when we get a referral for glaucoma, we jump in and treat, because a lot of the time it's so accurate. Not always, there are still the outliers, of course, because a lot of things can imitate a lot of other things, and it's not a perfect science, and machines do not replace people or experience, but there's a far less time wasting in a busy clinic when you have that really beautiful, accurate referral. So yes, glaucoma is one that, don't ever decline the opportunity to have a better, cleaner, more accurate, more thorough testing to any eye disease, but certainly not glaucoma. There's too many facets to it. It's got too many components to it to really know what's causing it, why the appearance of your eyes might be a little bit weird, why your pressures might be normal but that's still glaucoma. So many different considerations there. Now, if you have someone in your family, a grandparent, an auntie, an uncle, it's either a primary or secondary relative that actually has glaucoma, I would very much encourage you to take yourself to the optometrist well before you actually need another reason to go. Have a yearly exam. If there's someone in your family that has glaucoma, have a yearly exam. That's it. That's all there is to it. Do not wait until there's a reason, so to speak, to go to the optometrist, because that reason might come at a stage where it's, things are already progressing, and you might be some ways along the path with your glaucoma journey and not even know about it. Your pressures might be slightly elevated, you may not know about it, or you might be getting some changes to the optic nerve and no one's going to know about it until somebody has a look at the back of your eye and can actually diagnose that for you. It seems scary, and a lot of people do take the, bury the head in the sand approach, which is fair enough because it's a really scary thing to be facing. But the reality with glaucoma is the sooner you know, the sooner you can do something. And I'm a big fan of, prevention is cure. And when it comes to glaucoma, unfortunately, prevention is the only cure. So the only way you're going to ever be able to control glaucoma is to prevent its progress. At this stage, that's where the medicine is at. We're very good at controlling it, but that's all there is, control. There's no cure. And the earlier you jump in and control it, the earlier it'll stop damaging your eye. So that's always good news. Macular degeneration is another genetic one, highly genetic one. There's a lot of familial inheritance. We still don't know whether that's because of, again, that concept of the way that the blood flow into the eye, whether it's a vascular, generally a vascular component like blood pressure, for example, or how thin or thick your blood is, or other diseases involved. We really don't have a clear image. I have a lot of diabetics in the clinic that don't develop macular degeneration, but then again, I have a lot that do. I have a lot of people with uncontrolled high blood pressure, or previously uncontrolled blood pressure before we got to know them, that develop, issues with their eyes, and then there are others who do not. It's really very individual, and there's no clear anecdotal evidence in the clinic. But one thing I can say for absolutely certain is that if you have a relative that has macular degeneration, so we're talking probably parent in this case, or an auntie and uncle, or something like that, get it checked. You don't need any fancy equipment. All you need is for someone to have a look at the back of your eye and see if there's any pigment changes to the macula. It's so simple. There's no extra testing required unless they do see something wrong, in which case they might want to investigate, which is fair enough. But just to get a screening, you need nothing. You just need to rock up to an appointment. A lot of them are free or billed to the Medicare system here in Australia. I'm sure in other countries there are similar processes, and it's worth it. We're talking about once a year. With macular degeneration, maybe once every 2 years. It's a very slowly progressing disease. And the good thing, or the unfortunately good thing about macular degeneration is it is symptomatic. But again, if somebody tells you in your 60s or in your 50s that you've got some macular degeneration changes or some pigment changes to your macula, wouldn't you rather know then, when you can still have an opportunity to change your diet, to change your lifestyle, to make some, some decent headway, rather than wait until you have a real big problem and there's not really much that you can do about it because too little too late. You don't want to ever be in the position where you're a little bit older, things are a little bit harder, you've got other issues with your health because, age does that, and suddenly you're being told to change something, to eat better, or to, drink more water, things like that. It's not going to make an impact when you're 80, but it will make an impact when you're 50 and 60, or 20 and 30. So these are things that you've got to really screen for and be informed, because information is power in this case. The last one is amblyopia. Now, an adult will not develop amblyopia, typically. There are some rare cases, but that's not the ones I'm talking about here. I'm talking about a family who has a grandparent, let's say, that had a lazy eye. That's what amblyopia is. It's commonly known as lazy eye. It doesn't have to be an eye turn necessarily, or at least not a visible eye turn, but often is accompanied by an eye turn. Sometimes, and this is the patient I had today, is what happens. The patient's eye never turned. Just one eye was extremely long-sighted as a child, and the other one just normal. And as a result, the really long-sighted eye, it was blurry all the time. And that's what we call a refractive amblyopia. So had she worn glasses from a small child, from a young age, she would never have had the amblyopia. Or at least she would have had a far lesser amount. Today, that eye is legally blind. There's nothing that can be done about that. But what we did observe with her today, interestingly, is that when she has two eyes open, she does a lot better. When she has one eye at a time, even if it's the better eye, it's actually harder for her to see. So that second eye is still very much contributing to her sight. But of course, it would be much better to have two eyes that had 20/20 or close to it potential. So that was something that we've talked about today. And I said to her, even though there's nothing we can do about your eye anymore, because, it's too late, and she came in to me telling me, I've got a lazy eye, but I know it's too late, so she's obviously been informed about it all in the past. I said, well, do you have grandchildren? Nieces, nephews, great-grandchildren one day, hopefully. It's like, oh yeah. said, well, they all need to be screened, especially that she knows, and I'm about to tell you, that the only time that you can really reverse or improve a lazy eye is before the age of 4. Between 0 and 4 is when our visual system, and it ties into the way a little child develops. You're discovering your world, you're starting to really focus on things, general clumsiness and pottering about stops, and they start to get interested in books and pictures and things like that at around age 2 and 3. That's when the visual system is really, really, really making huge headway. That's your biggest opportunity to pick up a lazy eye. Till about 4, that system is quite plastic. There's a lot going on. It's very much moving and growing, and the cells are developing in the brain. Once you get to about 8, that door's shut. So up until 4, it's super, super flexible. It's making a lot of changes. Between 4 and 8, it slows right down, but it's still very much growing and developing and learning. And then you get to about 12, and that's gone, it's finished. So between 8 and 12, you still have some residual plasticity, but it's minimal, and it takes a hell of a lot of effort to wake up a system that's pretty much fully developed. And then after that, once sort of puberty hits, it's all over. So the eye only can really, or lazy eye can only really be jolted in childhood, or in toddlerhood more accurately. And the older that child gets, the less effect you can have. My little boy personally has had a lot of amazing improvement with just glasses and a tiny bit of patching. He's done really, really well in a really, really short amount of time, but we did pop him into glasses when he was 3.5, and by 4 he had restored sight, because that's how plastic it is at that age. Since then though, it's just been maintenance. There's been very little improvement to be made since then. And fair enough, we didn't expect it and didn't really need it, because he's got probably about 95 on his poorer eye and about 100% vision on his better eye. So we were lucky, and things got looked at quite quickly. But a child will never complain that something's wrong, because they think that what they see is how everyone sees. So to pick up a lazy, same thing. If you've got someone in the family that had a lazy eye, and as an adult was able to communicate that, every child in that family should then be screened at 3 years of age, and then probably again at about 5. These are the sort of time periods where you really pick it up and you can really do something about it. Alright guys, I hope you enjoyed today's video. Sorry about the croaky voice, I've just been a bit under the weather, but got all the oils happening and getting slowly better, which is great. If you enjoyed today's video and you'd like to see more of the same, please hit like, leave me a comment down below what else you'd like me to talk about. I do eyes, I do scarves, I talk about all sorts of things because I love to talk, so that's why I have this channel. I love it. So definitely drop me a comment below. For more things in my crazy world, do jump onto Instagram. There's definitely more stuff going up there more regularly. If you haven't already, please do subscribe. Very important step. Hope you're all doing really well out there, and I can't wait to see you on the next one. Bye!